There is a supply line running underneath your medicine cabinet right now that most people have never thought about, not once. It does not involve your doctor. It does not involve your insurance company. And it has nothing to do with the pharmacy down the street. It starts in chemical plants scattered across eastern China, Zhejiang, Shandong, Hebei, in facilities that most Western regulators have never physically inspected. And it ends with the pill you swallowed this morning. Here is the part that should bother you. If that supply line broke tomorrow, not hypothetically, not in some geopolitical thought experiment, but actually broke, your pharmacy would not run out of medicine next year. It would start running out within weeks. For some drugs, days. And the reason that timeline is so short has almost nothing to do with politics. It has to do with a decision the Western pharmaceutical industry made decades ago, quietly, without telling you, and has been trying not to talk about ever since. When most people picture how medicine gets made, they imagine a lab, white coats, clean rooms, maybe a factory floor stamping out tablets. That is the last 5% of the process. The other 95%, the part that actually determines whether the drug works, whether it exists at all, starts with something called an active pharmaceutical ingredient, an API. It is the chemical compound that makes the medicine do what it does. Without it, a pill is filler. Literally, it is chalk and binding agents shaped into a circle. And here is where the numbers start to get uncomfortable. China produces somewhere around 40% of all active pharmaceutical ingredients on Earth. For certain drug categories, that number is not 40, it is 80, 90. For a handful of critical compounds, it is functionally 100%, meaning there is no second source. Anywhere. Penicillin, the most widely prescribed class of antibiotic in human history. The last American manufacturing plant producing the raw material for it closed in 2004. Not 2004, in some slow decline sense. It shut down, doors locked, equipment sold. The production moved to China because it was cheaper and because at the time nobody was asking whether cheaper and safe were the same question. That was not an exception. That was the pattern. Ibuprofen. The base compound, the thing that makes it a painkiller, and not a breath mint, overwhelmingly sourced from Chinese manufacturers. Acetaminophen. Same story. Heparin, the blood thinner used in almost every hospital surgery in the Western world. China controls roughly 80% of the global supply of the biological material. It is made from pig intestines, specifically the mucosal lining processed in facilities that most importing countries take on faith are operating correctly. That last one already blew up once. But we will get to that. Now, if you have heard any version of this conversation before, you have probably heard India described as the pharmacy of the world. And that is true. India manufactures an enormous share of the globe's finished generic drugs, the actual pills, capsules, and injectables that patients receive. But here is the layer underneath that most people miss completely. India does not make most of its own starting materials. It buys them from China. Roughly 70% of the active pharmaceutical ingredients used by Indian generic manufacturers are imported from Chinese chemical plants. In some drug categories, antibiotics, certain cardiovascular medications, key vitamins, that dependency runs above 85%. So the supply chain is not. China makes ingredients. The West makes drugs. The supply chain is China makes ingredients. India makes drugs from those ingredients. And then your country buys the finished product from India. 2 layers of dependency. 1 choke point. And that choke point is not a shipping lane or a tariff schedule. It is a chemical plant in Zhejiang province that your government has no authority over, no inspection access to, and in many cases, no clear knowledge even exists. Let that sit for a second. The thing standing between a cardiac patient in London or Chicago or Sao Paulo and a potentially fatal shortage of blood pressure medication is not a hospital, not a stockpile, not a domestic factory. It is a purchasing agreement with a supplier 8,000 miles away, in a country that has more than once used export controls as a geopolitical tool. This was not an accident, but it also was not a conspiracy. It was an economics textbook playing out exactly the way economics textbooks do when nobody in the room is asking about risk. Starting in the 1990s, Western pharmaceutical companies, under enormous pressure to cut costs, began offshoring the production of active ingredients. Not the branded drugs. Not the patented blockbusters with the Super Bowl commercials. The upstream chemistry, the unsexy, margin-thin, regulation-heavy work of synthesizing bulk compounds. China offered three things no one else could match simultaneously. Labor costs that were a fraction of Western equivalents. Relaxed environmental enforcement. Chemical manufacturing is dirty, and cleaning it up is expensive, and scale. The Chinese chemical industry was enormous and growing, capable of absorbing production volumes that would choke smaller national industries. So the work moved. Not all at once, gradually, plant by plant, ingredient by ingredient. Each individual decision made perfect sense on a spreadsheet. Cut costs here, free up capital there, reinvest in branded research and development where the real margins live. Every CFO in the industry ran the same math and arrived at the same answer. No single company decided to make the West dependent on China for its medicine supply. But collectively, over 25 years, that is exactly what they did. And here is the detail that makes this worse than a simple offshoring story: the knowledge left too. When you close a chemical plant, you do not just lose the building. You lose the engineers who ran it, the process chemists who optimized it, the institutional knowledge of how to manufacture that compound at scale, reliably, to pharmaceutical-grade purity. That knowledge does not sit in a manual somewhere, waiting to be reread. It lives in the people who did the work. And those people retired, changed careers, or moved to industries that still existed domestically. So even if a Western country decided tomorrow full emergency, money is no object to restart domestic ingredient manufacturing, the timeline would not be months, it would be years, possibly a decade for certain compounds. Because you are not just rebuilding factories, you are rebuilding a workforce, a regulatory pipeline, a supplier ecosystem, and an entire layer of industrial chemistry that was allowed to quietly disappear. You do not have to imagine this scenario from scratch. You already lived a partial version of it. Early 2020. COVID-19 tears through Hubei province. Chinese factories shut down. Within weeks, Indian pharmaceutical companies started reporting raw material shortages, not rumors, actual shortages. The Indian government briefly restricted the export of 26 drug formulations, including paracetamol and certain antibiotics, because they were not sure they could keep their own supply stable. That was not a geopolitical move. Nobody was punishing anyone. Factories simply closed because of a virus, and the downstream effects rippled across continents within a month. Now, scale that up. Not a virus, a deliberate export restriction. China has done this before with other commodities: rare earth minerals in 2010, gallium and germanium in 2023. In each case, the mechanism was the same: new export licensing requirements that slowed shipments to a crawl, applied selectively, with no clear timeline for resolution. Apply that mechanism to pharmaceutical ingredients, and here is what the first 90 days look like. Hospitals, notice first. Not pharmacies, hospitals. Because hospitals use the highest volume, most supply chain sensitive drugs, heparin for surgeries, vasopressors for ICU patients, certain anesthetics, IV antibiotics. These are not drugs with large domestic stockpiles. They are manufactured and shipped on tight rotation because they are expensive to store, and many have short shelf lives. Within the first 2 to 3 weeks, certain surgical procedures start getting postponed. Not canceled with a public announcement. Quietly rescheduled. Pushed back. Elective at first, then increasingly less elective, because the supplies needed to keep a patient alive during and after the operation are running short. By week 4 to 6, the shortage hits retail pharmacies. Not all drugs at once. The ones with the thinnest margins and the most concentrated supply chains go first. Generic antibiotics. Certain blood pressure medications. Metformin, the most commonly prescribed diabetes drug in the world, whose primary ingredient source is, you already know. The public does not find out through a government announcement. They find out because they go to refill a prescription and the pharmacist says they are out. Or the pharmacist offers a substitute that is also running low. Or the pharmacist says there is no substitute. And then it gets political very fast. Governments are aware of this. That is not the problem. The problem is that awareness and action are separated by a gap the size of the entire global chemical industry. The United States passed legislation encouraging domestic pharmaceutical manufacturing. The European Union launched its own critical medicines initiative. India has invested in ingredient production parks to reduce its dependency on Chinese imports. All of these are real programs with real money behind them. None of them have changed the fundamental math yet. Here is why. Building a pharmaceutical-grade chemical plant is not like opening a factory that makes consumer electronics. The regulatory requirements alone, FDA approval, GMP certification, environmental compliance, stability testing for every compound take years before a single commercial batch ships. And the economics still do not work without either massive subsidies or a willingness to pay significantly more for domestically produced ingredients. That significantly more is the part nobody wants to say out loud. The reason Chinese ingredients dominate the global market is not just that China started earlier or scaled faster. It is that Chinese manufacturers can produce these compounds at a price point that no Western facility operating under Western environmental and labor regulations can match without government support. That is not a criticism of either system. It is just the math. And the math has not changed. So you get pilot programs, demonstration projects, strategic stockpile proposals that cover 30 days of supply for a handful of critical drugs. 30 days. Against a disruption that could last months or years. It is not nothing. But it is not a solution. It is a down payment on a solution that requires a level of industrial policy most Western governments have not practiced since the Cold War. There is one more layer here, and it is the one that almost never makes it into the policy papers. Quality. When you move production to the lowest cost supplier, you are also, by definition, moving quality control to a jurisdiction your regulators have limited access to. The FDA inspects domestic pharmaceutical facilities regularly. Foreign facilities? Less frequently. Chinese facilities specifically? There is a backlog measured in years, complicated by language barriers, travel restrictions, and the sheer number of sites involved. This is not theoretical. In 2008, contaminated heparin linked to Chinese suppliers was associated with adverse reactions in patients across multiple countries. The contamination was a deliberate substitution, a cheaper compound swapped in for the real one, and it was not caught by the supply chain's quality controls until patients started dying. The system was redesigned after that. Safeguards were added. Testing protocols improved. But the structural incentive that created the problem cost pressure pushing production toward the cheapest possible source. With oversight stretched thin across thousands of miles and hundreds of facilities, that incentive did not go away. It got stronger, because after 2008, even more production consolidated into fewer, larger Chinese suppliers, making the dependency deeper and the consequences of a failure bigger. Strip away the geopolitics for a second. Forget the trade war framing and the national security language and the cable news graphics of container ships. What this is actually about is a question that almost no one asked during the decades when the decisions were being made. What is the acceptable level of risk for something people cannot live without? Because the answer the market arrived at silently, iteratively, one cost-cutting decision at a time, is that there is no limit. That a 90% dependency on a single country for the raw material in a life-saving drug is fine, as long as the price is right and the ships keep coming. And the ships have kept coming. That is the thing. The system works. Right now, today. Your prescription gets filled. The hospital has what it needs. The supply chain functions. The question is not whether it works. The question is what happens on the day it does not. And whether the answer to that question is something your government, your health system, and your pharmacy have actually prepared for, or whether they are all just hoping the day never comes. Because hope is not a supply chain, and a pill without its active ingredient is not medicine. It is just a shape. If this one made you think, subscribe, because the next video is about something most people have even less visibility into, and the dependency might be worse. Drop a comment. Which drug running low would hit your life the hardest? I will read every single one.